Hello, everybody. Greetings from MedTalks IGCP group and from Pathkind. And we are in a series of webinars with you. And today we have a special webinar. There was a time we were focusing on antigen, but now the time has come to focus on antibodies, serological test, antibody test. We have heard about antibodies test in dengue, we have heard about in many other disorders. But here, COVID-19, after almost like 9 months of COVID-19, it has now become very important for us to understand all types of antibodies tests, A, E, M, G, and the most important here is IgG antibodies test. Then we have heard about neutralizing antibodies. We are talking about re-inflammation, reinfection, persistent infection, non-replicating virus persisting in our body. We have multi-system inflammatory disease in children, adolescents, and adults. To understand them, I have with me a special guest. I have Professor Ashok Ratan. After doing his MD, he did MAMS. He is an advisor to quality and research and development to Pathkind, who is our host today. He is a Commonwealth Fellow. He is a Fellow of INSA DFG. He is a CRO temporary advisor. He is a WHO lab director at CAREC, CAREC, PAHO, and he is an expert in this particular field. So let's listen to him for some time. And after that, we will have your question answers. I will first interact with him, and then we will have your question answers, which we will answer. So over to you, Dr. Ashok Ratan.
Thank you, sir. Can you see the slides? Oh, share screen.
Yes, we can see it now.
Good afternoon, everybody, and thank you, Professor Agarwal. Today, we will discuss about role of serology. I would talk about what is serology, what type of serological responses occur in COVID-19, against which antigens of the virus, and then focus on how serology can help in diagnosis and control of COVID-19 disease, and finally end with what serological tests are available and which can be used. So what is serology? Serology is humoral immune response of a person against any antigen. In this case, SARS-CoV-2 virus. Humoral immune response occur after about a week of infection. So it is delayed and cannot be used for making early diagnosis. But there's an early phase and subsequently the antibodies decrease, but memory cells are left. And that is why we are talking about decaying of antibodies and vanishing antibodies. Antibodies normally appear after 7 to 10 days, and generally it is IgM, which is the first antibody to appear. After some time, it switches to IgG. However, in COVID infection, sometimes it's IgM, which is the first antibody to appear. Oftentimes, IgG appears at the same time. And German scientists have been reporting that IgA levels are high and appear earlier than even IgG and IgM. Another report has indicated that not everybody produces copious amount of antibodies. Those patients who are who have suffered and recovered from critical illness produce higher titer of antibodies than those who have mild infection or have subclinical infection. The most prominent antigen is the nuclear capsid antigen. But the virus attaches itself to the ACE2 receptors found on the surface of human cells. So the neutralizing antibodies will be those which can prevent the binding of spike protein to the ACE2 receptors. This normally is best illustrated by the ability of the virus to form plaques, which are known as cytopathogenic effect on cultured cells, as you see on the right. And if we can neutralize that as plaque reduction neutralization test, this would mean that our plasma or serum has antibodies which can block the union of spike protein with ACE2 receptors. Since the virus is highly pathogenic, ICMR did not allow the culture of the virus in any lab which does not have BSL-3 facilities. So scientists elsewhere in the world have produced a pseudovirus which has spike proteins on the surface, but it is not the coronavirus. So one is we can do plaque reduction by using a pseudovirus. Recently, scientists genetically engineered the receptor binding domain of the spike protein as well as the ACE2 receptors. And then they have developed an ELISA which can be done in any equipped lab. This test is available in India. When it was tested in Singapore as well as in China, they could demonstrate very good separation between those who have neutralizing antibodies and those who have not suffered from the infection. So how can antibodies help? It was first reported from Wuhan that if you depend upon only viral RNA and RT-PCR, then at best of time, 80 to 85% of patients will be diagnosed. But if after about 9 days or so, you also add antibody detection, then both Liu and Gao found that your batting average improved from 60 to 70 to 80% to nearly 100%. Similar results were found in Boston, where they found that RT-PCR was the best method for diagnosing in the first 9 days. If the diagnosis was not established in a symptomatic patient in the first 9 days, then adding antibodies would be complementary and would help in diagnosis of infection. Today's paper indicate that in Mumbai, there were many persons who were reported as RT-PCR negative, but are now turning up with COVID infection, COVID symptoms. Serology could also be useful before we give convalescent plasma therapy. This would be obvious as the observation that only those who recover from very serious illness would produce antibodies, and they are unlikely to be in a position to donate plasma, while those who are healthy or suffered from mild or asymptomatic infection, they are unlikely to produce plasma and to produce convalescent serum, which will have neutralizing antibodies, and using their plasma would only be giving placebo. We had tested using two different methodology, and by using the antibodies against spike S1, S2, we find that only 20% of the total persons tested had a titer of more than 80, which in Italy was found to be positive for neutralizing assays. Serology can also be used for linking two outbreaks. This was illustrated in Singapore, where two visitors, W1 and W2, from Wuhan caused an outbreak in Church A. Subsequently, there was another outbreak in Church B, but no link could be found after repeated testing by RT-PCR. When serology was used, then A2 was linked to another outbreak, a family outbreak, and F1 from the family outbreak was linked because of serology to the second B church outbreak. Serology could also be used for screening of healthcare workers. Normally, healthcare workers should be screened every 2 weeks for the presence of antibodies. If they are negative, then they could be screened again. While if they become positive, then they should have RT-PCR to be done to find out whether they are positive by RT-PCR or negative. And new employees should have both RT-PCR and serology tests done. Symptomatic patients, of course, should have RT-PCR straight away. So for screening of healthcare workers, of frontline workers, of police and army administrators, serology could be used, which would be supplemented with RT-PCR. To answer the question, can I go back to work? A person we must address two issues. One, has he been exposed to the virus? And second, if a person has been exposed to the virus, does he have neutralizing antibodies? Even if positive, personal protection and social distancing should still be useful. Next is, before a surgery is performed, we could do antibodies. And if a person is positive for antibodies, surgery would be carried out and a person will be discharged after recovering from surgery and no exit test is required. It could also be done for surveillance, as ThyroCare has been doing extensively. Initially, they shared on 24th July, they shared 50,000 results with me. And on plotting, we find that in Mumbai and Dharawai, it was 40%, but in the rest of the country, it was about 20%. Subsequently, after they're done nearly 4.5 lakh tests, on 9 September, they shared the data indicating that in Dharawai, 57% of the population was already having antibodies and that the virus was spreading rapidly to nearly all parts of India. Now, what test should we do? Fundamentally, there are two types of tests available, though they are serology tests. One is looking at nuclear capsid. The second is focusing on antibodies against the spike protein. As I've tried to explain, antibodies against the nuclear capsid will inform about whether a person has been exposed to the virus. And since nuclear capsid is the most potent antigen, this test would be very sensitive. On the other hand, it's only when you have antibodies against the spike protein would you have protection. So the second group of tests would indicate whether a person has protection or not, again as a surrogate marker. We have used both type of tests. Roche Alexis test, which is a chemiluminescence test. It is against the nuclear capsid protein and it detects all types of antibodies. And we feel that for answering the question that whether a person has been exposed or not, this test is best. And as you noticed here, both by US FDA and in public health, it had done well. It had sensitivity of nearly 100% and specificity of nearly 100% with positive predictive value and high positive predictive value and high negative predictive value in case the prevalence is more than 5%. The second test that we've used is against this is against the spike protein, which will then give us information about whether a person has protective antibodies or not. So looking at the test available, there are two, looking at the antigen and the antibody that you look at, there are basically two different types of tests which can be used to measure whether exposure, surveillance, acute infection, recovered infection, immunity, and vaccines. Of course, none of this test is useful for acute infection. None of the tests will be positive in the first 7 days of infection. But if you want to answer the question whether a person has been exposed, then antibodies against the nuclear capsid protein, which are pan antibodies, so whether the response has been IgG, IgM, or IgA, we will pick that up. So that's the best test that is possible. And when you want to answer the question on whether the person has protective antibodies, then IgG against the spike protein, especially the receptor binding domain, would be the most useful as a surrogate marker. The 4 different tests, type of test available, rapid tests have found to be not very useful and is not recommended. ELISA is good, but chemiluminescence is even more sensitive. And PRINT, or that is plaque reduction neutralization test, is not advised by ICMR because of the virus and infectiveness of the virus, unless we have BSL-3 facilities. Unless we want to then use pseudovirus or the new ELISA, we would not be able to determine neutralizing antibodies. It's been suggested that to prevent cross-reacting antigens, we should do 2 tests. First is to answer whether a person has been exposed using the most potent antigen and using pan antibodies. So if using most potent antigen and all types of antibodies, a person is negative, then nothing needs to be done. But if a person is positive to the first reaction, then the second test should be done against spike protein, use IgG class of spike antibodies against spike protein, using chemiluminescence, and if that is positive, that means we have antibodies. And since this reaction is semi-quantitative, if we have titers of more than 80 arbitrary units per ml, that would mean we would have high levels of neutralizing antibodies. People have talked loosely about herd immunity. Herd immunity means protection that can occur after infection or after vaccination. Herd immunity means that the protection is that of uninfected. In this, as you notice, they say that looking at what is the chances of spread of infection, at least 60% of population must have immunity before herd immunity sets in. India has a population of 138 crores. For 60% protection, 82.8 crores need to be infected. If we take 0.5% as the mortality, that would mean that 41.4 lakh deaths would occur before herd immunity sets in all over India. So before vaccine is available, immunotherapy might be useful. And in this, if convalescent plasma, which had not been used wisely, is found to be difficult to get, antibodies against the virus produced in horse, which have been done by biology E, or monoclonal antibodies may be useful. But it's the vaccine which will then be able to protect large number of people. So my objective was to explain what the serology could do in controlling and diagnosing infection and what tests are available. Having done that, I hand you back to Dr. Agarwal. So you're mute.
I think we should go focus for some time in the last slide, because we'll put up questions so that audience can, all my viewers can go back and see that. Can I have the last slide, please? It was an extensive and lucid presentation by Professor Ashok Ratan. We'll make it more, we'll be asking questions. Large number of questions have come to us. But I come back to one basic thing, Dr. Ashok.
Sure.
When it comes to dengue, everybody knows NS1, IgG, IgM, everybody does. That if they to pick up whether the person has NS1 positive, if it is negative, then IgM will be positive. If both are negative, past infection, IgG will be able to tell. It's a routine for people today in dengue after so many years to do all three of them together. Do you feel that we must do, you are talking about 7 days, because 7th day is a very, we don't even know how the people will calculate their days. Do you feel that after 9 months, we should change our strategy and go and try to do an antigen antibody test together? Dr. Ratan.
So the antigen test is also useful. Actually, my own feeling is that RT-PCR is too sensitive. And wherever they've been able to do culture as well as RT-PCR together, which has happened in Germany, which has happened in Italy, in USA, and in Canada, they have noticed that the virus causes infection or causes plaques in cells for the first 8 days of symptoms. After that, it is not able to cause any infection. While RT-PCR may be positive for 5 or 6 weeks, the virus is able to cause a cytopathogenic effect. That means it is replicative. It is 8 to 10 days. Now, in biology, we need to be careful that these are averages, and they would be one off or two off where the virus has been found for longer duration. But in majority of cases, after 8 days, it is no longer infectious or replicative. And so RT-PCR is giving many false positives subsequently. As a consequence, an antigen detection which detects the pre-existing virus, fragment of pre-existing virus, may be more appropriate to find out whether a person is infectious or not. And since a large number of persons are asymptomatic or mildly symptomatic, antibodies may help in making a diagnosis, but it is not very early, so it will find out only those who have suffered in the past 2 weeks or so. In the presentation that then the slide that I showed you from Boston, after 3 weeks, majority of persons will become positive, those who have suffered from infection.
I agree. Normally we say IgG antibody get it done between 21 to 28 days. But what I am talking about is that as a primary diagnosis, along with, I'm putting a lateral thinking, along with primary RT-PCR, we start doing total antibodies, which contains IgM and IgG. Like we do NS1, IgM, IgG together in every case of dengue. Dengue serology means NS1, which is equivalent to antigen, which is equivalent to, because their RT-PCR is not available, their only antigen is available. We are checking antigen antibodies together. So why can't we do RT-PCR along with total antibodies? Unless, because what is happening is people are getting recurrent symptoms. They say, I got this symptom a month ago, before that also, and I don't know whether that was positive or now I am positive. So is there a role of doing both the tests together as a primary diagnosis? That's what I'm trying to say.
Sir, in this, the only, my first answer is yes, that if we do antigen and antibody together, we would be in a better situation to diagnose the case. But the only limiting factor is that in COVID, we want to diagnose an infectious case and isolate him at once. While in, that's why we want to do it, we want to diagnose within 7 days. But in case of dengue, even if a person has been sick for, even if we diagnose after 7 or 8 days, it really doesn't matter, because it's the mosquito that transmits infection. So a person is not infectious. So
again, putting a theoretical question. If I see ELISA and I do a combined antigen antibody test, if both are positive, which can happen because RT-PCR can remain positive for some time, and if antibody IgM has also appeared, then I know already 7 days are over. In that situation, I know he may not be infectious. That's my theoretical assumption.
I think you would be on the right side, sir. Of course, in science, we always have to produce data and we have to produce evidence, but it will be the right thinking that RT-PCR may be positive. If antibodies appear, then and as it's been already indicated, that the virus is infectious for the first 8 days. As we know, the antibodies appear around the 7th day. So there would be 1 or 2 days where there's an overlap. But with the appearance of antibodies, these are neutralizing antibodies as well as antibodies which may not be neutralizing. But once neutralizing antibodies are there, there is sufficient evidence to indicate that they are protective.
My second question is that when we talk about antibodies against S1, S2, or we are talking about nuclear capsid antibodies, one is for that infection has occurred and one is neutralizing. Which one appears first?
So the nuclear protein will appear first. because it is in the it is the most immunogenic. And spike protein antibodies will also appear, but they are not, the tests available are not 100% sensitive. So that we have had that discussion internally a number of times, that why shouldn't we do only spike protein? The problem is that antibodies, protective antibodies are against spike protein, but the test is not as sensitive as against nuclear protein. So nuclear protein will indicate whether a person has been exposed, but nuclear protein has specific antigens as well as genus specific antigens, so that other coronaviruses may also produce antibodies. And that
why can't I do both in a person? Why should I see people are going left and right on IL-6, which is not required. People are getting life and right. Every alternate day they are getting T-dimer, which is clinically not required. And why not I go for, when I'm talking about a comprehensive antibodies, I go for both the nuclear protein antibody, unless you say that both of them are interchangeable in terms of diagnosis.
no,
but if you say
they're not interchangeable. And as I said, nuclear protein is more sensitive. So that should be the what people have, what CDC has suggested is orthogonal testing. Orthogonal testing means two separate testing, but the wisest thing would be to do against nuclear capsid first, because that is 100% sensitive. If a person is negative, then there's no point in doing against spike. But if nuclear capsid is positive, then we should do spike also, but not do spike alone, because spike is not, it will miss some. So both tests are required. The first one,
I think this answers lots of our questions. When the people say that I am antibody tested negative and they are afraid, maybe they are getting a spike protein antibody test done, they are not going for the nuclear capsid antibody test. So therefore it is all the doctors who are watching this program, you must understand which test to advise and how to interpret, and their tests are not interchangeable. You may have a nuclear capsid positive antibodies and a spike antibodies negative. Are both them are also available in the total antibodies?
Sir, the nuclear capsid is available in total antibodies, and spike will be IgG.
Spike is only IgG, and nuclear capsid is total.
And this is total.
And nuclear capsid is also available, okay, as a separate, without a total.
Nuclear capsid is available as IgG also, as well as PAN. But if you're using this as a screening tool, then I would suggest that persons going for nuclear capsid and PAN, because then you're not missing. If a person is responding by IgM or IgA rather than IgG, then it
so
is.
I would say to all my viewers, all my colleagues who are watching this program is live on MedTalks YouTube, as well as this program is live on my Facebook. Make sure you watch it again and again, because many new things have come, specifically for me. I'm so well read, but even I have learned a lot today. So therefore, don't get confused. Watch this program again and again and again, and become a good COVID treating doctor. Remember, charity begins at home. First, look after yourself. Start doing your testing every 2 weeks. And when you are testing yourself, you need to take a nuclear protein test. Forget about seropositivity, that can come later. Seropositivity tests are basically done by people who want to donate their plasma, let them do it. But your evidence is whether you have developed this infection or not. And if you want to go for both. If you are nuclear capsid positive, then go for serology to see whether you have neutralizing antibodies present or not. Let's have some more questions from my viewers who are asking. I have, by this time, we'll do some rapid fire discussions. We have over 500 questions which have come. Take home message, yes, we will take SN Kumarji later on. If CT value is 29, so infection can spread. So is there any correlation of CT value in HRCT? This is what they are talking about in RT-PCR. Can you talk about something about CT value of RT-PCR, Dr. Ashok?
So I think we are going to discuss CT value in the next program that we'll have on
So we
2nd.
will have, but remember CT value, there are reports available which talks about CT value, whether you are less
Yes,
viral load or a high viral load.
I'm a very strong proponent of that, and I 100% endorse that, and I will give you evidences. And I'll give you one example where a 70-year-old colleague was isolating himself for about 60 days because his RT-PCR was positive. And the moment you look at the CT values,
34.
it becomes very clear. So we will discuss that on 2nd November, sir. And I'll explain that clearly. Sir, I may add something about IL-6 values. IL-6 is like a master of orchestra. And master of orchestra indicating that this is immunology has gone haywire. And before that occurs, you could do CRP, you could do ferritin, you can, and these will indicate that there is acute phase reactants are active. If acute phase reactants are active, only then should a person going for IL-6, and with the view that if IL-6 is raised, then you will give monoclonal antibodies, because then these monoclonal antibodies are against IL-6 receptor antibodies. They are against IL-6 receptor, and they will reverse the activity of IL-6. Though there is an indication that there may be bradykinin which is playing a role here. ACE2 receptors and ACE are involved in the renin-angiotensin pathway. And since ACE2 receptors and ACE are involved in with COVID-2 and SARS-CoV-2, bradykinin accumulates, and it is bradykinin which is causing the havoc that we're finding, along with the microemboli that occur.
I agree with you, bradykinin, because specifically people who have urticaria can only be explained if you explain the bradykinin pathway. In my personal experience, I have seen that CRP is the most sensitive. So the first one to raise will be ferritin, but you can basically manage with CRP because IL-6 will order the liver to produce CRP. And I have seen if CRP is normal, IL-6 will not be raised. That's like what we talk about in the nuclear capsid antigen and the spike antigen. If the nuclear capsid antibodies are absent, then spike antibodies are also absent. Similarly, if your CRP is normal, which is costing only 200, 250 rupees, that can be good enough for Indian people where IL-6 is not available. What titer of IgG is good for plasma therapy? Is there any titer? I mean, normally we talk about 1:80 is also okay. Can you explain it out? Yes. Question for Dr. Preeti.
So in the reports that came in from China, they had at that moment, they would only diluting the plasma. And they found that if they dilute, if the activity was present, neutralizing activity was present when the plasma was diluted 1:160, then that was suitable for giving plasma convalescent therapy. So it has, I think I showed a slide which was from Italy, indicating that if AU value of spike protein was 80, that will correspond to presence of neutralizing antibodies, which in the paper has said 160.
So more the better. 640 is better than 320. 320 is better than 160. And now we say even 80 will do, and you can go ahead with do it. But now with you have spike protein antibodies, titer also people are using to decide about the plasma therapy. She says, I'm 70-year-old doctor. I want to attend the clinic. What should I do? Go for every 2 weeks, go for IgG test. nuclear test and see whether you are positive or not. And rest of the precautions, of course, you need some precautions. And we always say masking, masking, and masking. Your clinic should be fully air ventilated, have good exhaust in your toilet, and make sure your patients take povidone iodine 3 times a day. Whenever they enter, they take a povidone iodine gargle, and you also do a povidone iodine gargles. He says platelets more than 160, persons with more than 160. What is more than 160? Malaria, Vivax positive, RT-PCR negative, platelet 55,000. Can it be due to? I couldn't understand the question, GNG. When you say more than 160 means what? Then you say RT-PCR negative. Are you talking about antibody more than 160? Probably is asking antibodies are more than 160, RT-PCR negative, and malaria Vivax positive. It's a coexisting infection with virus, get it treated. I don't think so there is anything, it's a straightforward. Means importance of IgG, IgM, he has already spoken. Yes, he's talking about Ig antibody. You haven't spoken about IgA antibodies.
So
Yes.
IgA Euroimmune, that is people from Germany, are they are very insistent that IgA is very good and it is very specific for making a diagnosis. But no other scientists in UK and USA, where we normally read all the papers from, they are not in agreement. So in a way, I have no personal data to be able to comment on it, except say that we should look at IgA, IgM, and IgG, and that's why we are recommending pan antibodies rather than IgG against nucleocapsid.
And at least 6 questions have come on reinfection. How do I suspect a reinfection? One is post 90 days when you are in a non-COVID situation. If your RT-PCR is positive, contact your government officials and say why your RT-PCR is positive after 90 days. What are the other options that when you suspect a corona reinfection, Dr. Shogati?
So my own understanding was that though there have been 40 million infections, the reinfections can be counted on fingertips. There is one classical reinfection of that person from Hong Kong who suffered from COVID infection while he was in Hong Kong. Then he went to Spain. When he came back at the airport, he was found to be infected. But he was asymptomatic. I think there's only one case where they said that on reinfection, the symptoms were higher. Biologically, it seems it's easy to explain that when a person has recovered, and if the person has neutralizing antibodies, then reinfection will be only recolonization. So there's nothing to worry. So I guess we should stress on what is important rather than on one-off cases when 40 million cases have occurred, 7 million in India itself. So I would not worry too much about reinfection. If a person has recovered and has antibodies, and before that there is evidence in monkeys that when a monkey recovers, when you try to reinfect the monkeys, it is not possible. So reinfection in monkeys is not possible. In Syrian hamsters, who are the indicator small animals for COVID infection, if you give them antibodies and then you challenge them, it's not possible to cause them infection. So the only then it would be that a person suffered from mild infection, did not produce antibodies, and therefore remain susceptible to reinfection.
So I come back to one more lateral thinking and a common situation. Suppose a person is positive with I'm talking about virus in and virus out. So I'm talking about the virus dose. And then I'm talking about the viral load, which is the out virus. In virus is the virus dose. So if the original virus dose is low and he has got a mild infection, he is still positive. He hasn't finished his 9 days. He is asymptomatic. He is working in a ward, which is COVID positive, and he's getting recurrent exposure to new patients. So he's getting recurrent in doses. Does it make a difference? I'm talking about a person who is positive, who is working in a COVID ward, or he is at home who is positive, and four other people are positive. They're living in the same house without wearing a mask. They're getting exposure to the viruses, newer and newer viruses for the first 6, 7 days till the antibodies are formed. Can that increase the severity of the acute infection?
So I think Monica Gandhi from California has addressed this issue. And she is, of course, again, this is only her thinking. And I'm just elucidating to that she feels that if we wear a mask, then mask will act as a filter and allow only a small amount of virus to infect us. As a consequence, this is like vaccination. And she feels that mask can act as filters and decrease the load. And if the exposure load is less, then your body would be able to get rid of the virus easily rather than be overwhelmed. On 2nd November, when we discuss about CT value, we would discuss about Pooja Das results from New York, in which she has indicated that if the initial viral load was more than 5.557 log, then the person did not survive and there was in-hospital death. But if the viral load was less at admission, then the person pulled through when they followed up 60 days after admission. So this was viral load performed at admission and then followed up for 60 days. So exposure of virus does make a difference.
So keep watching us. Look forward for a 2nd November seminar where we will talk about viral load, viral in, viral out. We'll talk about the CT value. We'll talk about the Argentinian study, which talks about that how masking reduces your chances of infection. Either it will prevent your infection or it will reduce your severity of infection. So people are now talking about masking is the first available vaccine. This is called as a social vaccine, provided you know which mask to use, provided you know it is 3-layer. The outer layer has to be water repellent, inner layer has to be water absorbent, middle layer has to be a melt-bound filter, and the splash resistance should be more than 120 millimeter of mercury. The breathability should be less than 49 Pascal per centimeter square. And the middle layer should have a 99% efficiency against bacteria and at least 80% efficiency against 0.3 micron particulate matter. And if you use them specifically, this is what we do in healthcare workers, we reduce our viral load. So therefore, it is always recommended that amongst doctors who are dying, and in Delhi, people, 50% of the people who died, I mean, large number of people who died belong to less than 40 years of age. What was the reason? We don't know. But maybe the answer comes on 2nd of November when we talk about the viral load. So keep watching us. Let me take few more questions. Otherwise, share this video again and again. And whenever you feel you are getting bored, watch this video, watch the slides. This is going to help you a lot in understanding the concept of serology, diagnosis, and everything. Let us pick up a few more questions if they are having. He says that if antigen and antibodies both are positive, is the patient infectious? We have answered this, but you can clarify it again.
So the antigen actually reflects pieces of the virus. That means once the antigen is present, that would mean a part of the virus is present and that person is infectious. There would be, as you know, since it is detecting the pre-existing viral load, normally it is present for say 2 to 3 days only, and then it decreases and antibodies take 7 days to appear. So it's a hypothetical situation that you're asking. Uh, but in case both are positive, then you should consider that virus is present and the person is infectious. On the other hand, there is evidence that subgenomic RNA persists for long period. And so RT-PCR positive need not mean that a person is infectious and it has a replicative virus. It is replicative virus which will cause infection to others. And I think CDC has also clarified that you need 15 minutes exposure and about 1,000 viruses to be transmitted to the person. For healthcare workers, I think we should be careful when we have lunch or dinner or tea with our colleagues. It is during that time that exposure is more. I think in Ohio study indicated that you do not get infection while working in ICU, COVID ICU, because during that time you are wearing PPE and you're on guard. It is when you are off guard and sitting with your colleague who might be asymptomatic that infection can occur.
I'm going to go back to the last test because there is some confusion which people are saying, and they're writing. A couple of questions have come because of your last statement. They want to understand the difference between antigen test versus the RT-PCR test. In one, you are checking the gene, in one, you are checking the antigen. So their question which is coming is after 7 days, if RT-PCR is positive, or after 10 days, you know it is a non-replicating virus. But after 7 days, if antigen test is positive, does it mean the same?
No, sir. Sir, what we're saying is antigen is a part of the virus. That means virus has been broken down into pieces by the lysis buffer, and then nuclear capsid is tested. That means the antigen, the virus is present. RT-PCR is detecting RNA which may or may not be present in the virus. It is subgenomic RNA. So antigen is positive unless it is cross-reacting. I think people have been saying that though somebody said that it's 100% sense, 100% specific, that may not be true because the nuclear capsid protein contains genus-specific antigens and it has species-specific. So it may not mean antigen detection may not be 100% always meaning that a person is having a SARS-CoV-2 infection.
No, it's not clear because we do get typhoid antigen positive, dengue NS1 positive, which may be false positive because of the cross reactions. But are you saying that the COVID spike protein antigen or the antigen test may be false positive?
Sir, not spike. This antigen detection is for nuclear capsid protein.
Okay.
And nuclear capsid protein has area which is shared with other viruses, other coronaviruses, the common cold coronavirus, and it has portion which is specific for SARS-CoV-2. Maybe it depends upon what is the situation, so that antigen detection is good. But I think the next test which is going to come is the LAMP test, which will be 20% better than antigen detection, and hopefully 20% less sensitive than RT-PCR, so that it will map. And I think on second we will discuss this in greater detail, how it will map the presence of replicating virus.
So I'm going to ask the last question. I just want to clarify for myself that if the patient is, uh, he has now 10 days are over, and if you go for a rapid antigen test, that's positive. So do you mean that isolation is not over?
Sir, in that would mean that he's still infectious. Yes, as far as I understand, that if on 10th day also he's antigen positive, then he should still be.
So are we saying that antigen test only what we are doing rat test, rapid antigen test, it is only done on nuclear acid rat, or do we also have a spike antigen test?
I'm not sure whether it's a mixture or they have purified it. It depends upon. I've looked at SD biosensors, and their guessing was it is nuclear capsid protein.
Nuclear capsid protein. So all my colleagues who are watching this program, again, I request you to watch this program again and again. Couple of things have come. Go back to your dengue serology. We asked for NS1 serology at the same time. Start thinking in which patient should I go for RT-PCR? Should I go for rapid antigen test? In patients, should I go for RT-PCR or rapid antigen along with a total antibodies? And if I'm doing a total antibodies, what is my purpose of doing a total antibodies? To see whether the virus had come or not, or whether I am protected or not. So with that, you will be able to find out whether you want to go for N antibodies or S antibodies, whether you want a total antibodies, and whether you want to go for an ELISA test or CLIA test. CLIA may be further better than ELISA. So don't go to the market and say which test is cheaper. Learn, empower yourself and decide, because you are the one who are going to interpret. Don't look at the report and say positive or negative. Maybe your patient may go into a confusion and a depression by finding his antibodies are not forming because you have chosen a wrong antibodies test and you have not chosen a test which is more sensitive, more specific. Maybe neutralizing antibodies are not there, but his nuclear capsid positive antibodies may still be present. So there is still a lot to come. This virus is teaching us a lot. That's all for today. Let me thank Dr. Professor Ashok Rattan to be here. And we will be back again with you with one more episode, Still Tat. Keep watching us, keep waiting for us. Till you have another session, keep watching our this session again and again. Thank you very much. Namaskar.
Thank you, sir.